Okay, let's unpack this. Welcome to the Deep Dive, the show where we take your sources, dive deep, and pull out the crucial insights just for you.
Hey there.
Today, we're plunging into a topic that's, well, seen its fair share of debate, hasn't it? Randomized controlled trials, specifically within hyperbaric medicine.
That's right. And we're using excerpts from a really solid chapter that focuses just on RCTs in this field. It gives a great structure to think about the evidence.
Yeah, it looks like a good guide. Our mission today is to really get to grips with this. We want to understand the evidence landscape, how it's generated, how you find it, evaluate it.
And ultimately equip you, the specialist clinician listening, to critically appraise the research you come across. It's all about navigating that evidence in practice.
Exactly. This is all tailored for you dealing with this stuff day to day.
Absolutely. So let's start where the chapter starts, the sort of landscape of evidence, and a pretty significant criticism that often comes up.
Perfect. Yeah, the chapter jumps right in, addressing that big criticism you often hear about hyperbaric medicine, that the treatments are based on, well, little, or sometimes, people argue, no good clinical evidence.
It's a strong claim, and the source points out why this is such a hot topic right now. There's just this huge increased awareness everywhere in medicine about evidence-based practice.
Right, relying on data, not just anecdote.
Exactly. So every specialty is under the microscope, and hyperbaric medicine definitely gets looked at through that lens.
And it's not just doctors thinking this way.
Yeah.
The source mentions funders generating reviews.
Yes, that's a big one. Think insurance companies, national health services,
Hmm.
the people paying the bills. They're demanding clear evidence of effectiveness before they'll cover hyperbaric oxygen therapy for different conditions. They want to see the data.
Makes sense from their perspective.
And tied into that are formal technology assessments. These are systematic evaluations of, well, technologies like hyperbaric oxygen, looking at effectiveness, safety, cost effectiveness. Healthcare systems use these to make big policy decisions.
So you've got this perfect storm, almost. Clinicians wanting evidence, funders demanding it, formal assessment scrutinizing it, all shining a spotlight on hyperbaric oxygen therapy.
And the criticism is, when you look, the perception is, well, maybe the good evidence isn't quite there in the quantity or quality needed.
But, and this is important, the source pushes back on that a bit.
It does. It presents a really crucial counterpoint. Despite that perception, it states clearly that many clinical randomized controlled trials investigating hyperbaric oxygen therapy have actually been reported. It's not like there's zero research happening.
Okay, so the perception might be little evidence, but the reality is many trials exist. That's a key difference.
It is. But, and here's the immediate caveat the source adds, while there are many trials, the chapter acknowledges their variable quality. That's the rub.
So quantity doesn't equal uniform quality. That probably fuels the debate.
Absolutely. Some trials are rigorous, others maybe less so, which makes interpreting the overall evidence tricky.
Okay, that really sets the scene. So the source then lays out its goals, which will be our roadmap for this deep dive. What are we aiming to cover?
Yeah, the author has some clear aims really useful for you as a clinician. First, just describing the place of RCTs within evidence-based medicine generally. Where do they fit in the big picture?
Got it. Understanding their role, fundamentally.
Precisely. Second, summarizing methods to actually find these trials in hyperbaric medicine, because, as we'll see, they can be scattered all over the place.
Yeah, that makes sense. Hyperbaric oxygen gets used in wound care, neuro, infectious disease. It's broad.
Exactly. Third goal, discussing how to appraise RCTs and, importantly, how to conduct them, but with a specific focus on the unique challenges you face in hyperbaric medicine. It's not just generic RCT stuff.
Okay, the hyperbaric-specific angle is key.
And finally, just providing context on the existing body of evidence, giving you a sense of the scale, how many RCTs and meta-analyses are actually out there.
And it mentions putting a special emphasis on the Cochrane collaboration's work.
Yes. Cochrane comes up quite a bit, highlighting their role in synthesizing all this evidence, which is vital.
And the source mentions an Appendix 1, a big list.
Yeah, it describes this comprehensive list of published RCTs and meta-analyses, all sorted by indication. We can't show the list here, obviously, but the scale is striking. The source says, as of January 2023, it had 416 citations covering 390 distinct trials.
Wow. 390 trials. That number itself really counters the no evidence idea pretty strongly. It's just, as you said, maybe variable quality or hard to find.
Exactly. That number tells you there's definitely a body of research to engage with and evaluate. It exists.
Okay, quick micro recap then. We've set the stage. There's this criticism about lack of good evidence in hyperbaric medicine. But the reality is many RCTs exist, though quality varies. This is highlighted now due to the rise of EBM, funder scrutiny, and tech assessments. Our roadmap, following the source, is to understand RCT's role in EBM, how to find them, how to appraise and conduct them, especially in hyperbarics, and get a sense of the existing evidence volume, including Cochrane's role.
Nicely summarized. So let's dive into that fundamental question. Why RCTs? Why are they often called the gold standard?
Yeah, this is crucial. The chapter explains that well-designed RCTs and systematic reviews that combine them are widely seen as the top-tier evidence for guiding clinical decisions about therapy effects. Why is that?
The absolute core reason, the defining advantage, is that RCTs are considered the best method for investigating causal relationships.
Meaning, does this treatment cause this outcome?
Precisely. If you want to know if giving hyperbaric oxygen directly leads to, say, better wound healing, an RCT is your most reliable tool for figuring that out.
And why are they so good for causality?
Right.
The source highlights their design.
It's all about their inherent low potential for systematic bias. Anything that skews the results away from the truth. Systematic bias is the worst kind because it consistently pushes results in one direction. RCTs are built to minimize that distortion.
Okay, and what specific biases are they designed to tackle? The source mentions a couple.
Yes, two main ones. First is selection bias. This really asks who gets which treatment. Without proper randomization, researchers might, consciously or unconsciously, put healthier patients or those they think will respond well into the new treatment group.
Or put sicker patients in the control group.
Right. And that makes the new treatment look better than it really is, just because the groups weren't comparable to start with.
So randomization stops that sorting?
Exactly. A truly random process means differences between groups at the start are just down to chance, not systematic selection. The second key bias is confounding.
Confounding. That's when other factors get mixed up with the treatment effect, right?
Perfect way to put it. Maybe the hyperbaric patients also get more attention or better general care, or maybe they're just more motivated. These other factors, if they're not balanced between groups, can make the treatment look effective when it's really something else causing the improvement.
So how does randomization fix confounding?
This is the really elegant part. Randomization aims to spread out all potential confounders, both the ones you know about and the ones you don't even suspect evenly across the treatment and control groups.
Wow, even the unknown ones.
Yes. Because the assignment is random, any other factor, known or unknown, has an equal chance of ending up in either group. With enough people in the trial, these factors tend to balance out, leaving the treatment effect isolated.
That is powerful. Controlling for things you haven't even thought of.
It really is. The source emphasizes that when you do randomization properly, especially with concealed allocation and blinding where possible, you eliminate systematic bias.
Yeah.
It takes everything out of the equation except the vagaries of chance.
Vagaries of chance. I like that phrase. It highlights the randomness.
It does. It means the assignment isn't influenced by the investigator's beliefs or the patient's hopes. The source gives examples: a doctor thinking hyperbaric oxygen works wonders, or a patient desperate for it to work. None of that influences who gets into which group if randomization and concealment are done right.
So the human element, the potential for bias, is removed from the allocation decision.
Correct. Then, once you have your randomly assigned groups, that's where statistical analysis comes in. Its job is to help you figure out if the differences you see in outcomes after the treatment are real or just due to those vagaries of chance.
Because even with perfect randomization, groups might differ slightly just by luck.
Exactly. Statistics help quantify the probability that the observed difference is just random noise versus a genuine effect of the treatment. This links to needing an appropriately empowered trial, enough patients to reliably detect a real effect if it exists. Too small a study, and you might miss a real benefit.
Which leads us nicely into how different study types are ranked these hierarchies of evidence the source mentions.
Right. Many groups have published these evidence hierarchies. They might differ slightly in the details, but the overall principle is the same. They rank evidence from types with the highest possibility of bias to those with the lowest possibility of bias.
And what's the general progression? Highest bias to lowest.
Usually at the bottom, with the highest potential for bias, you find things like single-pace reports or expert opinion that isn't explicitly based on a critical look at the evidence. Just someone's experience or belief.
Makes sense. Very susceptible to chance or personal bias.
Totally. Then you move up through observational studies, case series, case control studies, cohort studies. These look at associations in the real world, but because there's no randomization, they're more vulnerable to confounding and other biases.
And at the peak, the top of the pyramid.
That's where you find well-conducted, appropriately powered RCTs. And considered even stronger by many hierarchies are systematic reviews with meta-analysis, where you rigorously combine the results of multiple high-quality RCTs.
The source gives a specific example, Table 1, from the Oxford Center for Evidence-Based Medicine. Can we walk through those levels? They're pretty standard language.
Yeah, absolutely. So level 1A, the very top, that's a systematic review of RCTs where the results are homogeneous, meaning the studies basically agree and it makes sense to pool their results statistically.
Okay, the strongest signal from multiple consistent good trials.
Exactly. Level 1B is a single individual RCT, but it has to be high quality and have enough power. Still strong, but one trial isn't as definitive as several pointing the same way.
Level 2A.
Now we move to systematic reviews of cohort studies. Again, looking for homogeneous results among the included cohort studies. Remember, cohort studies follow groups over time, but without random assignment.
And Level 2B.
That's an individual cohort study. Interestingly, the source puts low-quality RCTs here, too. Like an RCT where maybe less than 80% of patients were followed up, too many dropouts, can really bias the results.
That's key. Even an RCT drops down if it's poorly done. Quality is vital.
Absolutely. Level 3A. Systematic reviews of case control studies needing homogeneous results. Case control studies look backward, comparing people with a condition to those without, searching for past exposures.
Level 3B.
An individual case control study, generally seen as more prone to bias than cohort studies because of that retrospective nature.
Getting lower down, higher bias risk.
Yep. Level 4 is case series just describing a group of patients with a condition or treatment, no comparison group. Also includes poor quality cohort and case control studies. Very hard to draw causal conclusions here.
And finally, Level 5, the base level.
Level 5 is the weakest evidence for intervention decisions. Single case reports, expert opinion that hasn't critically appraised the evidence, just based on authority, or recommendations based only on physiology or lab work without clinical data in people.
Okay, that Oxford hierarchy gives a really clear structure for thinking about study, quality, and bias potential. From Level 5 anecdotes up to Level 1A systematic reviews of consistent RCTs. Invaluable for clinicians.
Absolutely, a fundamental tool for EBM.
Now, the source also mentions classifying RCTs themselves. Not all RCTs are the same type.
That's right, they can differ. One way is by their overall design structure. The most common is the parallel group design. That's the classic setup. You're randomized to either treatment A or treatment B or placebo, and you stay in that group for the whole study.
The standard image of a trial.
Pretty much. The source briefly mentions other designs like crossover, factorial, cluster trials, noting they have specific uses in certain situations, but parallel group is the main one we see.
But it highlights another really important distinction, crucial for applying results. Explanatory versus pragmatic trials.
Oh, yes, this is vital for you as a clinician. Let's break down explanatory trials first. Their main goal is to show efficacy.
Efficacy meaning, can it work?
Exactly. Can this treatment work under ideal conditions? So explanatory trials often enroll a very specific, narrowly defined group of patients, maybe pure cases, no complex comorbidities.
A clean, homogeneous group.
Right. And they're done under highly controlled conditions. Strict protocols, maybe extra monitoring, things that might not be typical in a busy clinic. They're designed to maximize the chance of seeing the treatment's effect, to show its biological potential.
Okay, so explanatory shows if it can work in a perfect scenario. What about pragmatic trials?
Pragmatic trials aim to show effectiveness.
Effectiveness? Meaning, does it work in the real world?
Precisely. Does it work in a typical clinical situation? So they use more inclusive entry criteria. They enroll patients who look more like the diverse mix you actually see in practice with comorbidities, different severity levels.
More like my actual patient population.
Exactly. And crucially, the way the treatment is delivered, the follow-up, the outcomes measured, it's all designed to mirror routine clinical practice. It reflects the messy reality.
That difference seems massive for deciding if the study applies to me. An explanatory trial shows hyperbaric oxygen might work ideally, but a pragmatic one tells me if it's likely to work for the patient in front of me now.
Absolutely. The source notes that many trials fall on a spectrum between these two extremes, and this is why critically appraising a trial means looking hard at its external validity, its generalizability. You have to ask, were these trial patients like mine? Was the treatment delivered realistically? Are the outcomes relevant to my practice?
Yeah, it's not enough to know if it worked in this study. You need to know if it's likely to work for your patients in your setting.
Couldn't have said it better. Internal validity ensures the result is true for the study group. External validity tells you if it's relevant outside that group.
Okay, micro recap 2. We establish why RCTs are the gold standard for causality, low potential for selection bias and confounding thanks to randomization. We walk through the evidence hierarchy, Oxford levels 1A down to 5. And we highlighted the critical distinction between explanatory trials, efficacy in ideal settings, and pragmatic trials, effectiveness in real-world settings, stressing the need for clinicians to assess applicability, external validity, to their own patients.
Right. Now let's tackle a really thorny issue, especially relevant for hyperbaric research: the ethics surrounding randomized trials.
This brings up clinical equipoise.
Mhm.
The source says this was traditionally seen as fundamental. What is clinical equipoise?
In its traditional sense, it's the idea that there's genuine uncertainty or disagreement within the expert medical community about which treatment is best for a given condition. If the experts genuinely don't know, then it's considered ethical to randomize patients because you're not knowingly giving anyone inferior care.
So the field has to be collectively unsure to justify a trial.
That was the traditional view, yeah. Though the source mentions it's been challenged and evolved more towards a community standard. But focusing on that traditional idea, it creates a real problem for hyperbaric researchers. They might personally disagree with the prevailing uncertainty or skepticism.
How does that play out?
Well, the source describes a common scenario. Many non-hyperbaric doctors might think hyperbaric oxygen therapy has little or no value for a condition. Maybe they're skeptical. But the hyperbaric specialists, maybe they've seen it work, strongly believe it does have value.
So you have these opposing, strongly held beliefs among different expert groups.
Exactly. And by the strict traditional definition of individual equipoise, neither group feels ethically comfortable randomizing. The hyperbaric doc feels they'd be withholding effective treatment from the control group. The skeptic feels they'd be exposing the treatment group to something useless or unproven.
Sounds like a complete deadlock.
Yeah.
A research stalemate, as the source calls it.
Precisely, a research stalemate. If everyone's already convinced, one way or the other, based on that traditional view, mounting the high-quality trials becomes ethically problematic for the individuals involved.
And this stalemate actually affects the field's progress.
The source directly links it to that earlier criticism about lacking evidence. This ethical stalemate is a partial explanation for why hyperbaric oxygen therapy might not get the research attention or funding it needs. The very nature of the disagreement hinders the generation of definitive evidence.
That's a profound point. The lack of evidence isn't just about lack of effort. It's partly an ethical barrier born from the controversy itself.
And this isn't unique to hyperbaric medicine, the source notes. It happens in other areas with controversial or non-mainstream therapies.
Is there a way out? The source mentions a different take on equipoise.
Yes, it introduces a concept called behavioral equipoise, discussed by Ubel and Silbergleit.
Behavioral equipoise, how's that different?
The core idea is that you can ethically conduct a trial, even if you as the researcher are personally convinced the treatment works.
Wait, that sounds like it violates the traditional idea completely. How is that justified?
If the widespread use of that therapy is being prevented because the rest of the medical community, the referring doctors, the payers, the hospitals, don't believe it works or remain unconvinced, and therefore aren't using it widely.
So the equipoise isn't just in your head, it's reflected in the behavior of the medical system. If the system isn't routinely providing the treatment due to uncertainty or disagreement, a trial is ethical to resolve that.
Exactly. The ethical justification shifts from individual certainty to the collective uncertainty or disagreement that's evident in actual clinical practice patterns. The argument is that controversy often stems not just from lack of data, but from differing values, experiences, and biases influencing how people interpret existing data and act on it. Behavioral equipoise says if the behavior reflects this uncertainty, a trial is ethical.
That really reframes the ethical possibility for research in controversial areas like some hyperbaric applications. It offers a path forward.
It potentially does, and it connects to another point the source makes. The extraordinary claim requires extraordinary proof idea. For many doctors unfamiliar with hyperbaric oxygen, the idea of treating, say, chronic brain injury with high-pressure oxygen in a special chamber seems, well, extraordinary.
And if it seems extraordinary, the bar for evidence is higher.
That's the principle. It helps explain why the demand for really rigorous, high-quality evidence, particularly RCTs, is often so intense in hyperbaric medicine compared to more conventional therapies.
Okay, micro recap 3. We tackled the ethical challenge of traditional clinical equipoise in hyperbaric medicine, where strong opposing beliefs can create a research stalemate. We introduced behavioral equipoise as a potential way forward, suggesting trials can be ethical if clinical practice reflects uncertainty or lack of adoption, even if individual researchers are convinced. And we noted the extraordinary claim, extraordinary proofs principle, contributes to the high evidence bar in this field.
Right. Now let's zoom out slightly and talk about evidence-based medicine, EBM itself. This context is crucial for understanding how RCT evidence actually gets used.
The source makes an interesting point that EBM as a practical process only became feasible relatively recently. Why?
Simple answer: electronic libraries and search engines. Before that, just keeping up with the sheer volume of medical literature published every year was impossible for a practicing clinician. Digital access changed everything.
So EBM tools are basically ways to harness that flood of information.
Pretty much. They help navigate the overload. And the source gives that classic definition of EBM: the integration of best research evidence with clinical expertise and patient values.
The three pillars: evidence, expertise, and patient values.
Yeah.
Not just the evidence alone.
Absolutely critical. All three are needed. But the source notes, despite enthusiasm for EBM, many clinicians have criticisms or misunderstandings about it.
What kind of criticism?
Well, some fear it erodes their clinical freedom, forces them into protocols, ignores their experience.
The cookbook medicine idea.
Exactly. Or the fear that it's just designed by administrators, the bean counters, to cut costs, not improve care.
A cost-control tool in disguise.
Right. Or that it demands treating everyone with the same diagnosis identically, ignoring individual needs.
But the source calls these unfortunate misconceptions.
It does. It argues EBM is fundamentally designed for practitioners as a tool to help them. It explicitly requires synthesizing the best available evidence with clinical expertise and experience.
So it's meant to empower clinical judgment, not replace it.
That's the core idea. The goal is to use that synthesis plus patient values to find the best approach for each individual patient. It's about informing individualized care, not mandating uniformity.
That directly counters the cookbook fear. It's about better ingredients for personalized recipes, maybe.
Good analogy. And here's a really crucial point the source makes, especially given our focus. EBM does not require randomized evidence for every single decision.
Whoa, hang on. We just established RCTs as the gold standard. How can EBM not require them?
It's about using the best available evidence. RCTs are the highest level for treatment effectiveness when feasible. But sometimes they aren't feasible, or ethical, or even necessary.
Like when?
Think very rare conditions impossible to get enough patients for an RCT. Or conditions with all or none outcomes. If a treatment suddenly cures a previously fatal disease, even a small case series might be compelling.
So what evidence is acceptable in those rare situations?
The source suggests things like well-constructed case registries or even robust retrospective case series can be powerful enough in those specific contexts, provided you appraise them critically.
That's vital for hyperbaric medicine, which treats some rare things like gas embolism or severe CO poisoning where RCTs are tough.
Exactly. So EBM is not about slavishly following only RCTs. It's about critically appraising the best evidence available, whatever form it takes for that specific question, and integrating it with expertise and patient values.
So when the source mentions a paucity of RCT evidence for many hyperbaric indications, how should we interpret that in an EBM context?
Interpret it carefully. Lack of RCTs doesn't automatically mean no evidence, or that the therapy is wrong if other credible evidence exists, like strong physiology, good case series for rare conditions, and RCTs are genuinely impractical or unethical for that specific indication. Use the best you have, critically.
It's nuanced. Avoid simplistic dismissal, but stay critical of the evidence quality you do have.
Precisely. It requires sophistication. But the source warns, practicing EBM well takes effort and specific skills.
What skills are needed?
Asking focused, answerable clinical questions, efficient literature searching, critical appraisal, really evaluating study quality and validity, understanding basic clinical statistics, and crucially, relating the findings back to individual patients.
These sound essential across all medicine, really.
They are foundational skills. The source points to classic resources like the 1992 JMA paper and Sackett's Pocket Guide for learning them.
Okay, micro recap 4. EBM integrates best evidence, clinical expertise, and patient values. It's not rigid cookbook medicine or just cost-cutting. It aids individualized care. Crucially, it uses the best available evidence, which isn't always RCTs, especially for rare conditions. Practicing it requires skills in question formulation, searching, critical appraisal, basic stats, and patient-specific application.
Right. Now, let's get practical. How do you actually find the evidence, especially RCTs, in hyperbaric medicine? The source details the systematic search strategy used to build its big appendix lists.
Right, that list of over 400 reports and 390 trials. How did they compile that?
It was a multi-stage process, updated over time. January 2013, May 2018, and January 2023 are the dates mentioned. Shows it's an ongoing effort.
And the keywords they used.
Pretty straightforward. Adapted for each database. Hyperbaric oxygen therapy, hyperbaric oxygenation, and randomized trial.
Simple, targeted.
Yes. And they explicitly note the chapter and appendix exclude most diving medicine RCTs, except for the treatment of decompression illness, which overlaps. Focus is clinical hyperbaric therapy.
Got it. So what was the step-by-step search process?
A really systematic approach. Step one was using a specialized database. The database of randomized controlled trials in hyperbaric medicine, or DORLAR CTIHM.
A database just for hyperbaric RCTs. That sounds amazing.
It's incredibly valuable, freely available online via the Undersea and Hyperbaric Medical Society website. And it doesn't just list trials, it includes short, formalized critical appraisals and info on clinical impact.
Wow, so some pre-digested analysis included.
Exactly, and it's actively maintained and updated by contributing authors, a living resource.
Okay, start specialize. Step 2.
Step 2 was searching the Cochrane Database of Systematic Reviews, CDSR. We'll talk more about Cochrane later, but it's the major hub for systematic reviews.
Step 3.
Step 3 was a broad search of Medline via PubMed, the huge, comprehensive biomedical database. Essential catch-all.
Right, cover the major bases. Step 4.
Step 4 was hand-searching specific, relevant journals published since 1965, manually checking tables of contents and abstracts in key journals.
A bit old-fashioned, but thorough.
Very thorough. Catches things electronic searches might miss due to indexing quirks or odd phrasing, especially useful in niche fields.
And Step 5.
Step 5 was citation searching, looking at the reference lists of the papers they found and maybe who cited those papers later, snowballing outwards.
Using the found evidence to find more. Smart. How do the results stack up at each stage?
The source provides a table showing the yield. Step 1, DOR RCDIHM, found 239 reports, 179 trials, plus 13 meta-analyses, cumulative. 239 reports, 179 trials. A good starting point.
Okay. Step 2, Cochrane.
Cochrane search yielded 250 reports, 190 trials. Cumulative total went up to 250 reports,
Wow.
190 trials, indicating it added unique studies not in DOR RCDIHM.
And Step 3, Medline.
Medline found 206 reports, 191 trials, but the cumulative total jumped significantly here to 292 reports, 222 trials. Shows Medline caught a lot the others missed.
Really highlights needing multiple databases, doesn't it?
Absolutely critical for comprehensive searching in a field like this. Step 4, hand searching. Hand searching added 128 reports, 102 trials. Cumulative total climbed again to 301 reports, 229 trials. So yes, manual searching found unique studies too.
And Step 5, citation review.
Interestingly, Step 5 found no new citations beyond what the first 4 steps had already uncovered. Cumulative stayed at 301 reports, 229 trials. Suggests the previous steps were pretty exhaustive for this particular search.
It's a really rigorous approach, and the source clarifies these numbers initially included diving studies too, right?
Yes, the raw search results covered both, even though the chapter focused mainly on clinical hyperbaric therapy, except DCI. Just explains the initial numbers.
Okay, micro recap 5. We've detailed the systematic search strategy used to find hyperbaric RCTs, starting with a specialist, DRCTIHM database, then Cochrane, Medline, hand-searching key journals, and citation review. The results clearly showed that multiple sources are essential to capture the scattered literature, highlighting the value of a comprehensive approach.
Exactly. So, now we know how to find the evidence. Let's talk about evaluating it, appraising RCTs, and also conducting good ones.
The source kicks this off by saying, quite rightly, that not all RCTs are created equal. Some are more valuable than others. How do you tell the difference?
It comes down to critically examining the trial for threats to its validity. The source distinguishes between 2 key types, internal validity and external validity.
Okay, let's start with internal validity. What's that about?
Internal validity asks, was this study done right? Are there flaws in its design or execution that undermine confidence in the results? Basically, can we trust that the observed effect is really due to the treatment and not some bias or error in the study itself?
Got it. It's about the study's own rigor and integrity. What about external validity?
External validity is about generalizability or applicability. We touched on this with pragmatic trials. It asks, even if the study was done perfectly internally, do the results apply to my patients in my clinical setting? Were the patients studied too different? Was the treatment delivered in a way I can't replicate?
Ah, so internal is true finding for the study group. External is relevant finding for my patients. Both crucial.
Absolutely essential. You need both for evidence to be useful in practice. The source mentions in Appendix 2, described as a checklist of key questions to ask when appraising a study.
A practical tool to guide your critical reading.
Exactly. It helps ensure you systematically check all the important aspects: randomization, blinding, follow-up, analysis that affect validity. A high-quality trial should report all these things clearly. Using a checklist stops you from just focusing on the conclusion and missing critical flaws.
Helps standardize your appraisal. Makes sense.
And the source points out this checklist for appraising a good trial also tells you what you need to focus on when designing and conducting one.
The same criteria apply whether you're reading or doing the research.
Two sides of the same coin. Key things to emphasize when conducting an RCT include sound sample size calculations, getting the power right, rigorous allocation concealment, protecting the randomization, diligent blinding of patients and assessors where feasible, and using appropriate statistical analysis.
The source mentions some examples of good trials to look at.
Yeah, it suggests looking at the appraisals for Sifu 2014 post-concussion and Londol 2010 diabetic ulcers on the HPO evidence site as examples of well-conducted hyperbaric RCTs.
The source also stresses ethical review and trial protocols.
Yes. Ethics committees, IRB-SRECs, are essential. They demand a detailed protocol outlining the methodology, justification, procedures, and safety plans before approving a human trial. You have to convince them the study is necessary and ethical.
Making the case clearly.
Right. And the source wisely advises researchers to write a detailed protocol, even if not strictly required, just because the process forces clear thinking and planning, which is invaluable for success.
There's also a really important point about how to analyze the data, especially dealing with patients who don't stick to the plan.
Yes, this is absolutely critical. Intention to treat analysis. It's a fundamental principle.
Intention to treat. What does that mean exactly?
It means you analyze all participants in the group they were originally randomized to, regardless of whether they actually received the full treatment, switched treatments, or dropped out. Once randomized, always analyzed in that original group.
So even if they barely got the treatment, they stay in that treatment group for the analysis. Why?
Because it reflects reality. It tests the effect of the strategy of assigning that treatment in a real-world setting where compliance isn't perfect. It gives a more realistic estimate of the therapy's effectiveness in practice, not just its efficacy in perfectly compliant patients. It preserves the benefits of randomization.
Ah, it links back to that pragmatic versus explanatory idea. Intention to treat gives you the pragmatic, real-world answer.
Exactly. The source notes you can do a secondary analysis, maybe a per-protocol analysis, looking only at those who fully complied. But that tells you more about the effective compliance itself, and like the overall effectiveness of offering the treatment strategy. Intention to treat is the standard for the primary analysis.
Okay, micro recap 6. We covered critical appraisal, focusing on internal, study, done right, and external, applies to my patients, validity, using checklists. Key elements of conducting good trials include sample size, allocation concealment, blinding, stats, and protocols. And, crucially, we explained intention to treat analysis, analyzing patients in their original groups, as the standard for assessing real-world effectiveness.
Perfect. Now let's address a common issue in hyperbaric research: pilot studies and the problem of underpowering.
The source observes that many hyperbaric trials are just too small. They're underpowered to reliably detect important differences.
Yes, that's a frequent limitation. An underpowered study might find no difference simply because it lacked the statistical muscle to see a real effect that was actually there. A false negative, essentially.
And this connects to why we see so many pilot studies.
It does. Many trials are presented as pilots, meant to inform a later, larger study, but the source points out a big problem. Often, that larger definitive study never happens.
So we get stuck with inconclusive pilot data.
Exactly, which doesn't really help clinical decision-making. Now, the source agrees it is reasonable to do preliminary studies, often based on physiological rationale. Understanding how hyperbaric oxygen might work suggests where it could be tested.
Using basic science to guide clinical exploration.
Right. And as we learn more about mechanisms, new applications should be explored, maybe even revisiting old ones. If preliminary work suggests promise, then planning a definitive trial makes sense. But the source calls the pilot study approach a two-edged sword.
Okay, what are the two edges, the pros and cons?
The advantage, one edge, is a pilot might save you from launching a massive expensive RCT if the treatment looks unlikely to work based on the pilot data. It helps test feasibility, refine methods, estimate effect size for better planning.
Testing the waters before diving in. Makes sense? What's the downside, the other edge?
The disadvantage is the pilot might consume so much time and resources that the definitive RCT never gets launched. Funding runs out, momentum fades, or people mistakenly think the pilot's suggestive results are enough.
That's a huge risk. The pilot kills the main event.
It can happen. Because of this, the author suggests it's often more useful to just go straight for the definitive RCT from the outset if there's already decent rationale.
Skip the pilot. Isn't that risky?
You manage the risk with regular interim analyses during the definitive trial. You analyze the data at pre-planned points.
But you need strict rules for that, right?
Absolutely. Predefined stopping rules are essential. They dictate when to stop early, either for overwhelming benefit, unethical to continue controls, or clear futility harm. And this needs oversight by an independent data safety and monitoring committee.
So go big, but build in safety checks and early stopping points with independent oversight. Gets a definitive answer more efficiently, potentially.
That's the argument. If preliminary data suggests a reasonable chance of an important clinical effect, maybe just do the definitive trial with interim looks.
What about the dangers of just adopting hyperbaric oxygen based on weak or no data?
Big risks. Risk of inappropriate use giving it when it doesn't help, wasting resources, potential side effects, risk of withholding other effective treatments because you're focused on the unproven one.
And a critical long-term risk for research itself.
Yes, this is crucial. If hyperbaric oxygen becomes the accepted standard for something without trustworthy RCT data, it becomes ethically very difficult, maybe impossible, to do an RCT later.
Because you can't ethically randomize patients away from the standard of care, even if that standard was adopted prematurely. The Equipoise problem bites again.
Exactly. Premature adoption poisons the well for future research. Wait for the evidence.
The primary goal of any trial, pilot or definitive.
To see if hyperbaric oxygen therapy changes the outcome in a way that's important to patients. Clinical significance, not just stats.
Yeah. And researchers need to watch out for confounders like the natural history of the disease.
Yes. Know how the condition behaves on its own. Also, be aware of the placebo effect, benefit from belief, and the Hawthorne effect, changing behavior because you're being studied. These can inflate perceived benefits.
Always need good controls and blinding to account for those non-specific effects.
Definitely.
Okay, micro recap 7. We discussed underpowered trials and the two-edged sword of pilot studies in hyperbarics, useful for planning but risk-derailing definitive trials. We explored doing definitive RCTs from the start with interim analyses and DSMC oversight. We stressed the risks of adopting therapy without solid data, including compromising future research via lost equipoise. And we noted the need to consider natural history, placebo, and Hawthorne effects.
Right. Now, let's focus specifically on calculating that crucial sample size.
The source says it's not guesswork. You need specific inputs. What are they?
3 key things you must estimate to calculate sample size. First, the minimum clinically significant difference. This is the smallest change in outcome that patients and doctors would actually consider meaningful in practice. How much improvement matters?
Not just statistically detectable, but clinically worthwhile. Tricky to define sometimes.
Very tricky, but essential. Second, the base rate in the control group. What's the expected outcome rate for patients getting standard care or placebo? You need that baseline.
Third,
The acceptable errors. How much risk are you willing to take of making a wrong conclusion?
what are the standard acceptable error rates?
Traditionally, 2 main ones. A 1 in 20 chance, p-point 0.05, saying the treatment works when it doesn't. That's a type I error alpha, a false positive. And usually a 1 in 5 chance, corresponding to 80% power, of missing a real effect if it exists related to the type 2 error, beta, a false negative.
Okay, so estimate minimum important effect, know the control group's rate, set alpha, usually 5%, and power, usually 80%. Plug those in.
Plug those into the formula, yes. And the source points out that in hyperbaric medicine, the resulting sample sizes are often so large that you really need a cooperative multi-institutional study to recruit enough patients in a reasonable time.
because single centers often don't see enough patients with specific conditions quickly enough.
Exactly. And this need for huge numbers, plus the pressure researchers feel to publish something, helps explain why we see so many smaller, underpowered pilot studies. The definitive study just looks too daunting.
So the sample size challenge itself pushes researchers towards less conclusive studies sometimes. A practical constraint.
A major practical constraint impacting the evidence base.
Okay, micro recap 8. We covered the inputs for sample size calculation. Minimum clinically significant difference, control group base rate, and acceptable type I alpha 5%, and type 2 beta power 80% errors. We link the often large sample sizes needed in hyperbarics, requiring multi-center studies, to the prevalence of pilot studies due to feasibility and publication pressures.
Good. Now let's look closer at two pillars of trial rigor we've mentioned: concealed allocation and blinding.
The source says good trials try to mask treatment knowledge from 3 groups as possible.
Yes. The patient, the therapy providers, and the outcome assessors. Keep them in the dark about who's getting what.
Let's start with allocation concealment. What's that?
This happens right at enrollment before treatment starts. It means the person enrolling the patient cannot predict which group the next patient will be assigned to. They can't know beforehand if it's active or control.
So they can't game the system, like holding back a sick patient if they know the next slot is the active treatment, prevents selection bias at the entry point.
Exactly. It protects the randomization. The source gives examples of failed concealment, simple alternation A, B, or having the person who generated the random list also enroll patients. Proper concealment uses things like sequentially numbered opaque sealed envelopes, SNOSE, or central phone or web randomization systems that only reveal the assignment after enrollment is confirmed.
Okay, concealment protects the enrollment process. What about blinding, often double blinding?
Blinding happens after allocation. Double blinding typically means masking the treatment identity from the patient and the outcome assessor. If neither knows who got what, their expectations or biases are less likely to influence symptom reporting or outcome measurement.
Sometimes the therapy providers can be blinded too.
Ideally, yes, triple blinding. But that's often the hardest part, especially with procedures like surgery or hyperbaric therapy.
Right. How do you blind hyperbaric therapy? It seems obvious if you're in a chamber getting pressurized.
It's definitely a challenge. The source says blinding requires using some kind of sham treatment, something that mimics the real thing but lacks the active therapeutic element.
And the source describes 3 main ways to do a hyperbaric sham.
Yes. Method 1. Minimal pressure, maybe just enough to pop ears while breathing normal air. Simulates the experience, pressure changes, sounds, and closure without significant hyperoxia or pressure.
Feels like a dive but isn't really therapeutic.
Right. Method 2. Brief pressurization at the start, then return to normal pressure, breathing air or oxygen for most of the time, then another brief pressure excursion at the end. Again, simulates the procedural sensations without sustained exposure.
Mimics the start and end phases.
Yes. Method 3 is more physiological. Pressurize to the full treatment depth, but have the patient breathe a reduced oxygen fraction. The aim is to make their alveolar oxygen partial pressure the same as breathing normal air outside the chamber.
Wow, match the oxygen level despite the high pressure, trying to isolate the pressure effect from the oxygen effect.
Exactly. Trying to control for oxygen while delivering the pressure stimulus. Each method has pros and cons depending on the research question and presumed mechanism.
What's a potential downside of method 3, the reduced oxygen at full pressure?
A key issue is nitrogen. To reduce oxygen, you increase nitrogen in the breathing mix. At pressure, this increases the nitrogen dissolved in tissues.
Which increases the risk of decompression illness.
Potentially, yes. There's an increased risk of DCI compared to the active group breathing high oxygen, which minimizes nitrogen. So the sham itself introduces a different physiological effect and risk profile, which could be a confounder.
A tricky trade-off. But the source says blinding can work with these methods.
Yes. It cites studies showing effective patient blinding with both minimal pressure, method 1, and nitrogen substitution, method 3. Patients couldn't reliably tell sham from real.
And even blinding the staff.
Amazingly, yes. 2 studies cited found that even experienced divers and hyperbaric attendants couldn't reliably distinguish true from sham compressions when tested. Shows sophisticated blinding is feasible.
That's fascinating. Even the experts can be fooled by a well-designed sham.
It demonstrates it's possible, though challenging.
Okay, micro recap 9. We covered allocation concealment, protecting randomization at enrollment, and blinding, masking treatment after allocation, usually patient and assessor. We detailed the three main hyperbaric sham methods: minimal pressure air, brief pressure normal air, full pressure low O2, noting their goals, and the potential nitrogen issue with method 3. And we highlighted evidence that both patient and even staff blinding is achievable.
Good summary. Now, just a brief mention of statistical analysis, as the source does.
The source makes a very strong recommendation here.
Absolutely. It strongly recommends trialists get advice from a qualified clinical statistician right from the planning stages of any trial.
Not just at the end for analysis, but involved from the start.
Definitely. They provide crucial guidance on sample size calculation, choosing the appropriate statistical tests, and importantly, the source notes. The very process of working with a statistician to define the protocol clearly is invaluable for ensuring a rigorous and successful trial. It forces clarity.
Helps sharpen the whole research plan.
Exactly. But as you said, the source notes a detailed discussion of specific statistical methods is beyond its scope.
So key takeaway: involve statisticians early and often.
That's the critical message.
Okay, micro recap 10. Emphasize the vital role of early statistician involvement in trial planning for sample size, test selection, and overall protocol rigor. Noted specific statistical methods are beyond this source's scope.
Right. Now, some general help and advice resources mentioned in the source.
First up is the consort statement. What's that?
CONSORT stands for Consolidated Standards of Reporting Trials. It's basically a checklist and flow diagram providing evidence-based recommendations on exactly what information should be reported in an RCT publication. It helps researchers design studies, write clear papers, and helps you as a reader critically appraise them.
A standard for transparent reporting.
Precisely. And most major journals now require adherence to CONSORT for publishing RCTs. It's become the expected standard. You can find it online.
Very useful. The other big topic is trial registration.
Yes, this is huge for transparency. In many places, like the U.S., it's mandatory to register clinical trials on a public registry, like clinicaltrials.gov, before you enroll the first patient.
Registering the plan publicly up front.
Exactly. The source mentions clinicaltrials.gov had details on over 444,000 trials globally. Similar requirements exist elsewhere. And crucially, many top journals won't publish trials that weren't pre-registered.
So registration is basically essential now for credible research. Why is it so important? What's the main purpose?
Transparency. Specifically, transparency about the predetermined outcomes the researchers plan to measure before they saw the data.
Why is pre-specifying outcomes so critical?
To prevent reporting bias or outcome switching, that's where researchers might, after seeing the results, decide to emphasize a secondary outcome that looked good while downplaying or ignoring the primary outcome that didn't show a benefit. Or they might report only positive interim results. Pre-registration forces them to commit to their main outcomes up front.
Stops people moving the goalposts or cherry-picking positive findings. Improves the integrity of the literature.
Absolutely. It holds researchers accountable. The source notes clinicaltrials.gov listed 267 hyperbaric trials at the time, maybe 200 being RCTs, with hot topics like COVID, diabetic wounds, radiation injury, and post-concussion syndromes.
So registries give you a snapshot of current research activity.
Yeah, a valuable window.
Okay, micro recap 11. We discussed CONSORT for standardizing trial reporting and aiding appraisal. We covered mandatory trial registration, like clinicaltrials.gov, for transparency, especially regarding pre-specified outcomes to prevent reporting bias, and noted the significant hyperbaric research activity visible in these registries.
Right. Now for the section on recent methodological controversies, focusing on a key example.
The source highlights the ongoing controversy around treating chronic phase head injury.
Yes, a very contentious area, driven by strong patient advocacy and the prevalence of post-concussive injuries in military personnel returning from conflict.
Which led to significant military funding for research.
It did. The U.S. military funded several large RCTs looking at hyperbaric oxygen for chronic post-concussion and PTSD symptoms.
And the findings of those large military-funded trials using standard methods.
The source states they suggested little objective benefit from hyperbaric oxygen compared to a sham control.
No significant difference between hyperbaric oxygen and sham in those studies.
That was the finding for the objective measures. But the source stresses the area remains highly controversial.
Where does the controversy lie, methodologically?
A key argument from some proponents is that the standard sham procedures used in those trials, and maybe generally, are not valid.
Why not? What's their argument against the shams?
They argue that any exposure to pressure in a chamber, Even minimal pressure or breathing-altered gas is physiologically active. It's not an inert placebo.
So the sham isn't truly a sham, it's an active comparator.
That's their position. They argue a true inert sham for hyperbaric oxygen cannot be devised. Therefore, they advocate for different trial designs.
Like what? What do they propose instead?
They advocate for unblinded randomized trials.
Unblinded. But wouldn't that introduce huge bias, especially for subjective concussion symptoms?
That's exactly the crux of the controversy. Their proposed design usually compares hyperbaric oxygen plus standard care to standard care alone, with everyone knowing who gets what. They claim their trials using this approach do show a benefit.
So conflicting results depending on the methodology used, blinded sham-controlled versus unblinded standard care controlled.
Precisely. Their assertion is the best comparator is standard treatment alone, accepting the lack of blinding, because they believe a true sham is impossible.
A fundamental disagreement on methodology.
It is. And the source notes a practical consequence. A proposal to add chronic post-concussion syndrome to the Undersea and Hyperbaric Medical Society's list of accepted indications was not successful.
So the main professional body isn't convinced by the current evidence, likely considering this methodological debate.
Seems so. The debate is ongoing and vigorous. The source refers to papers by Mitchell and Bennett from 2014 for more detail.
And the author's take on resolving this.
The author suggests the controversy has further to run and might only be resolved by finding a mutually acceptable form of sham exposure. Finding a control method that satisfies both sides might be key.
Okay, micro recap 12. Focused on the head injury controversy. Large military RCTs using standard shams showed little objective benefit, but some argue these shams are invalid active comparators. These critics advocate unblinded trials against standard care, claiming positive results, leading to conflicting findings and ongoing debate. UHMS hasn't accepted the indication, and resolution might require a mutually agreed-upon sham method.
Exactly. Now let's turn to the organization that helps make sense of all these trials. The Cochrane collaboration.
The source starts by reminding us why synthesis is needed.
Yes, it reiterates that well-designed double-blind RCTs are the gold standard. But the problem in hyperbaric medicine, as we've said, is many trials were small, underpowered, or had applicability issues.
Leading to conflicting results from individual studies.
Right. Small trials often contradicted each other, making interpretation difficult. This is where Cochrane comes in. It's described as an international, nonprofit, independent organization
Dedicated to.
making up-to-date, accurate information about healthcare effect readily available worldwide to help healthcare workers and patients make informed decisions.
And their main way of doing this.
Producing and disseminating high-quality systematic reviews of healthcare interventions. They also promote the conduct of needed trials.
They weren't the first to do meta-analysis, but they systematized the review process.
Correct. Meta-analysis techniques existed, but Cochrane, starting formally in 1993 after initial work in 92, really structured the systematic review process and made it global.
And the scale now. The Cochrane Database of Systematic Reviews, CDSR.
Huge. As of January 2023, over 8,900 systematic reviews across medicine. Specifically for hyperbaric oxygen, there were 41 such reviews included in the source's appendix, a significant body of synthesized evidence.
How else can these reviews be used, beyond just efficacy?
They can be combined with economic data to estimate cost-effectiveness, crucial for policy and resource decisions. Some such analyses exist.
So does it work, and is it worth the cost? Cochrane helps with the does it work part.
Exactly. But a crucial caveat from the source.
Let me guess. Even Cochrane reviews need critical appraisal.
You got it. Publication in Cochrane doesn't guarantee freedom from errors or bias. You must read them critically, just like any other research. The reviewers often have strong opinions in their field, which is understandable.
But the argument is, Cochrane's rigorous, transparent methods make potential biases easier to spot than in less systematic traditional reviews.
That's the counter-argument. The explicit methods offer a better chance of identifying potential issues compared to opaque narrative reviews. They're still a cornerstone of EBM, but require diligence from the reader.
Okay, micro recap 13. Cochrane collaboration plays a vital role synthesizing evidence, especially needed in fields like hyperbarics with scattered or small trials. Their mission is accessible, accurate info via systematic reviews, 41 on HBO2. These inform efficacy and, with cost data, cost effectiveness. But crucially, even Cochrane reviews need critical appraisal. though their transparent methods help identify potential biases.
And that brings us nicely to the chapter's conclusion, wrapping up our deep dive.
It summarizes the unique role of RCTs.
Yes. While not the only valuable method, RCTs have a unique role due to their low propensity for bias and ability to help us assume causality when done well.
And it circles back to that initial criticism about hyperbaric medicine lacking evidence.
It does, countering it by pointing out there are actually many relevant RCTs, citing that large compiled list. The historical problem was they were hard to find, scattered across dozens of specialties.
Like needles in many haystacks.
Exactly. But access has improved recently. Better electronic search engines and, importantly, those dedicated hyperbaric RCP databases like DOR CDHM. They've made finding the evidence much easier.
Which helps clinicians actually practice EVM in this field.
It does. The conclusion then reinforces the need for clinicians to develop skills in critical appraisal and basic interpretation of medical statistics.
Using checklists is suggested as a practical approach.
Yes, a systematic way to evaluate studies. Finally, the conclusion acknowledges the reality. Good clinical research is time-consuming, costly, and difficult. This chapter only touched on a few key issues.
An intro, not the exhaustive guide to doing research.
Right. Those interested in conducting trials are encouraged to read more detailed texts on methodology.
Wow, okay, that was incredibly thorough. A real deep dive into RCTs and evidence in hyperbaric medicine, pulling everything from that source chapter. It's clear there's a lot of research, but also real challenges in methodology, ethics, and synthesis.
Indeed. Understanding these nuances, the principles of good research, and how to critically appraise what you find is just essential for specialist clinicians in this area.
All right, let's wrap up with a final thought for you, our listener, to mull over, building on everything we've discussed. Given that ongoing vigorous debate about sham controls, the ethical dimensions of equipoise, especially for controversial indications like chronic head injury, where blinding is tough and beliefs are strong, how should the hyperbaric community navigate this? How can they produce evidence that's both scientifically rigorous and ethically sound, convincing the broader medical world? Is it refining current shams, finding totally new controls, or maybe embracing frameworks like behavioral equipoise more explicitly to justify trials even amidst disagreement?
That's the million-dollar question, isn't it? No easy answer, but reflects the ongoing work needed to strengthen the evidence base.
Absolutely. Well, that concludes this deep dive into randomized controlled trials in hyperbaric medicine. We've extracted the key insights from the source material on the evidence, the methods, the challenges, the resources. We really hope this equips you, the specialist clinician, to navigate the literature in this complex field with more confidence and a sharper critical eye.
Keep engaging critically with that literature. Apply those EBM principles. It's fundamental to providing the best care.
Thanks so much for joining us for this deep dive. We'll catch you on the next one.